Hello and welcome to Everyday Medicine. I'm Dr. Luke, and I'd like to thank you all for joining me on this podcast series where we share conversations with colleagues exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this podcast, we're talking with an expert on regenerative medicine using stem cells and exosomes. Before doing so, for Australian audiences, listening does give you eligibility for your CPD, so log in and add this as an activity. You may also consider journaling, reflection, and adding to the review and performance section in your CPD. The field of regenerative medicine is receiving significant interest with the objective of restoring damaged tissues to health using biological products as well as influencing age-related decay. The use of pluripotent stem cells has been studied for some years now with the hope of nurturing their undifferentiated state into specific cell types reflecting the target tissues requiring repair. Another approach has been to harness the biological properties of exosomes. Exosomes are nano-sized biovesicles which are released by all nucleated cells into surrounding body fluids upon fusion of tiny intracellular multivesicular bodies and the plasma membrane. And these small vesicles measuring between 40 and 160 nanometers were first identified in the late 1980s. They were initially proposed as cellular waste resulting from cell damage or byproducts of cell homeostasis with little or no effect on neighbouring cells. And this initial simple interpretation of their function has now been supplanted by new insights into their physiological roles. So exosomes carry a complex cargo of proteins, lipids and nucleic acids and are now recognised as functional vesicles capable of delivering very important cargoes of information to target cells they encounter. This chemical messaging may ultimately reprogram the recipient cells remotely from their release and represent a novel mode of intercellular communication, as well as playing a major role in many cellular processes such as immune response, signal transduction, and antigen presentation. Well, it's likely that the cargo of exosomes may differ significantly depending upon the function of the originating cell type and its current physiologic state, including states of transformation, differentiation, stimulation, or stress. A current line of study aims to determine whether active exosome cargo may offer prognostic information on a range of diseases such as chronic inflammation, cardiovascular and renal disease, neurodegenerative diseases, lipid metabolic disease and tumours. Well, additionally, as exosomes are not immunogenic, they're being examined for their potential to actively deliver biologic therapeutics across different biological barriers to target cells, including across the blood-brain barrier. It's a fascinating area of research. And in this podcast, we have a conversation with Dr. Jeffrey Gross on the application of neonatal stem cells and exosomes in the field of regenerative medicine. Well, Dr. Gross is a spine fellowship-trained neurosurgeon who has pivoted his practice of surgery to offering precision therapy directed at joint and cartilage regeneration using stem cell and exosome treatments and has expertise in managing athletic injuries of the hip, knee, shoulders and spine. He has both an undergraduate degree in biochemistry and molecular cell biology from the University of California, Berkeley, as well as a medical degree from the George Washington School of Medicine and Health Sciences. He's a member of the American Board of Neurological Surgery after residencies in neurosurgery at the University of California Irvine Medical Center and subsequently undertaking a fellowship in spinal biomechanics at the University of New Mexico. He is a founder of Recelebrate, which focuses on anti-aging and regenerative medicine and is considered a pioneer in this field. Well, it's going to be a fascinating conversation. Please welcome Jeffrey to the podcast. So, Dr. Jeffrey Gross from the United States, it's a great pleasure to have you here on Everyday Medicine. Thank you. Welcome to Australia, Jeffrey. You've never been to Australia before, so this is your virtual tour of Australia. You can see my office. It's gloomy outside. Melbourne offers a lot of gloom as we approach the winter time, which is why we have a football session in this state, Jeffrey. But I can see it's nice and sunny there in Nevada. Looks beautiful. We're really very interested in talking with you about regenerative medicine, the field you've entered into, and stem cells and exosomes, so things that are just emerging as treatments here in this country, I think, and you're clearly more advanced in the United States. So I'm very excited to talk with you about your work and where you think this is heading for medicine. Couldn't you give us a little background, Jeffrey, before we run into the science of what you're doing? Tell us, where did you come from? What's your journey to here?
Sure, and thank you, Dr. Luke, for having me on. This is my honor, and I'm a traditional neurosurgeon, spine fellowship trained neurosurgeon by training, and I practiced for over 20 years, taking care of neck and back pain and other neurosurgical problems. I know you've had a neurosurgeon on the show not too long ago, and I was further away from the brain side of things, even though I did treat the brain, and fell in love with the spine during my residency. And for 20 years, I gave advice on back pain, neck pain, therapies, injections, medications, exercises, and if need be, for the minority of those patients who failed those treatments, certain surgeries. And it was out of frustration for the lack of advancement and patients, clamoring for other options that I dug back in and pursued additional training and education late in the game in regenerative medicine. And a lot had happened since I attended my undergraduate and medical school days in that field, in the field of molecular biology and biochemistry, and our understanding of the cellular processes. And it really re-inspired me and reinvigorated things. So I now find myself having entered into regenerative practice to be an additive tool for my spine practice, instead performing almost most of my work on patients just in regenerative medicine, more for nervous system and spine. I mean, we're looking at joints and many other issues now, and it's just blossoming.
When we say regenerative medicine, Jeff, what are we referring to exactly? By that, do you mean using biological tools rather than surgical tools to enhance tissue redevelopment, growth, and restoration to normal health?
Correct. Anything from the platelet-rich plasma, which should sort of be the lower introductory end of regenerative medicine offerings, through stem cells, through stem cell-derived signaling factors called extracellular vesicles, or for short, exosomes.
Yes. Okay. Well, take us through that. Just how does this all work? Just can you explain this to us? And the whole concept of exosomes, which I think they were discovered in the 1980s, is relatively new. And I've asked some of my colleagues in preparation for this chat today, tell me about exosomes. This has been my question to my colleagues, and they've all said, I've heard about them, but I don't know much about them. It's fascinating, isn't it? Can you tell us a little bit about this?
Well, in medical school, we took some biochemistry, and we learned that cells both produce and receive small vesicles. Small vesicles have membranes and can carry some type of contents, biological or biochemical contents. A cell may want to rid itself of waste.
Yes.
And there are endosomes that form inside the cell and work their way to the surface. And then some cells take in, like macrophages, take in things, and other cells take in by endocytosis, membrane encapsulated small vesicles to receive their contents. Well, it turns out there's quite a significant amount of cellular signaling and intercellular communication by virtue of these small vesicles. Vesicles typically measured between 50 and 150 nanometers across, roughly about 1/1000th the diameter of a regular cell, are coined exosomes. And these are typically for the purpose of one cell delivering out into its local environment, into the extracellular matrix, signaling molecules about the activities inside that cell to influence other cells to behave similarly. But if a cell is undergoing inflammatory defense activities, it should recruit its neighbors to help. And that's what it's doing, for example.
It's fascinating. It's fascinating because we thought cells communicated through the tight junctions or the hormonal influences, which is true, or through cytokines. And here we have another way
Right.
cells communicate, which it's another world, isn't it, within ourselves,
Right.
that's going on, looking after us, we're the exoskeleton almost for what's going on internally. I think this is absolutely fascinating. So we've got these exosomes, which have these cargoes of lipids and proteins, nucleic acids that are communicating.
Right.
And we've got the stem cells, which are cells that haven't yet differentiated. They're waiting to
Right.
enter a part of our body which it requires regrowth, or maybe we're going to talk about bone marrow, we're going to talk about other forms of stem cells. Perhaps I'll ask you just to define stem cells in a little more detail then as well. Can you tell us about stem cells?
Yeah, when we look at stem cells, there are various types of stem cells. When we're an embryo, we have these embryonic, omnipotential cells. They can form anything. They can form a limb, given enough space and time. But as we develop, from a fetus to a newborn and into a young child, those cells go from, omnipotent to pluripotent to multi-stage stem cell, which we harbor inside of our body through our entire life. And we tap upon those cells to reinvigorate our innate sense of healing. How do you heal a cut? How do you replace and renew your skin cells or your hair or liver cells? But really other cells, those are just the most notable ones. Skin being visibly notable is that you have new skin cells all the time. Yeah. But how do you heal a cut? What mechanisms are called for, and where are those cells, and where are they harbored, and what are they doing? Well, it turns out they're very active in releasing exosomes. And when we use the word exosome, any cell can make an exosome. A cancer cell can make an exosome. We're for, at least in the therapeutic sense, stem cell derived exosomes or stromal cell MSC derived exosomes. And these are what are available in the community now.
So what part of the body are they being harvested from, those mesenchymal stem cells?
Well, generally speaking, if you are to have a PRP procedure for tendonitis or something, you're getting these enriched healing factors and proteins and growth factors and what have you. But you're also getting the extracellular soup, the milieu, the what's in the plasma contains exosomes. So if you're concentrating the growth factors, you're concentrating some exosomes. So you're getting some anyway.
Yes.
Same with stem cells. If you're getting stem cells, whether it's from your own body as an autograft or from a perinatal donor, you're getting stem cells who are delivering exosomes. Turns out the stem cells, if you get a stem cell allograft, it only lasts about 10 to 14 days in your body, but the benefits can last much longer and even do enough repair so you don't have the clinical issue anymore. Those are because those stem cells are delivering exosomes. You think about it, Doc, look at a pregnant lady. Her skin is wonderful. It's glowing. She feels great, has probably very little pain, maybe except some low back pain if she's carrying low. And, her hair growth is wonderful. Why? She's getting a constant dose of exosomes from her baby. She's getting regenerative medicine for 9 months, and she should, because evolutionarily, she needs that protection to be able to survive and carry on the species, right? So that's what we're seeing.
Okay, yeah, that's very interesting. And so you're using exosomes and some stem cells. Where are you? Well, you go to a source for these, I imagine, or maybe you source them yourselves. Are you taking them from? You mentioned there about a neonate. You can also source them from the abdominal fat pads and so forth. I understand they're quite rich in stem cells. Where are you getting them from?
Right. So you're 100% right. You could take these from fat tissue. You can take them from bone marrow, which is really the richest source.
Yes.
And the older the patient is, I really don't love to use these auto harvests because when you change the oil in your car, you don't put the old oil back in, right? If obese tissue, for starters, obese tissue could be pro-inflammatory. We don't want exosomes giving off a bad signal. Mm-hmm. So my favorite source is actually from reputable, approved, and certified labs that process donor tissue that is after birth. So after a mother delivers by C-section, they for quite some time here, thousands of years, we've been throwing away the placenta, except in some cultures where they bury it or slice it up with liver and onions and eat it, I guess. But the placenta, the umbilical cord, the amniotic fluid are rich in both MSCs, which are the umbilical cord stem cells and stromal cells, and growth factors and the amniotic contents and exosomes. And we know this as a neurosurgeon. We used to do, intrauterine surgery for spina bifida, where we would close the spinal defect in utero. Yeah. And those babies, when later born, would come out without a scar. So we know there's something magical about the amniotic environment.
Yes.
And I think exosomes have a lot to do with that.
Yes, that's fascinating. So it doesn't matter if you're using it because it's a donor. Is there any concern about rejection? Is that a concern at all for?
Not really, no. The exosomes have minimal, if any, cell surface markers, major histocompatibility markers. So they don't. They're not recognized as foreign. In fact, stem cells don't represent many of those either. These type of perinatal biologics from an allograft donor are immunoprivileged, so we don't see rejection problems.
Okay, so that's sort of immunologically inert. So these sources you're taking them from, is someone in a laboratory actually just giving you a soup of stem cells plus exosomes, or are they able to somehow identify the stem cells, separate them, and through centrifugal work perhaps just get the exosomes? Is that how they do that? So you're getting a soup with exosomes. Okay.
We can get either, but I prefer to have the ultra centrifugally separated nanoparticles or exosomes, and for a few reasons, if I may. They are easier to handle and last longer. I can store them here in a minus 30 C freezer. The stem cells require minus 80 C, which we have, but it's a lot easier to handle. They last longer. They penetrate further in tissue. They're cutting out the middleman, if you will. Right. The stem cell really is a deliverer of stem cell derived exosomes. They penetrate the blood-brain barrier when delivered intravenous. So anything we want to do to affect the nervous system really do better with direct exosome than they do with stem cells. And they're about half the cost.
Okay, yes, where stem cells don't penetrate the blood-brain barrier.
Correct, they're too big.
So thank you for giving me that background. Tell us about how you're using it, how you're applying this kind of therapy.
Where our low-hanging fruit is really joints and spine, treating what can be called osteoarthritis, what can be called bone-on-bone, and the radiologists call it chondromalacia, wearing away of the cartilage. And this is really a process of losing the ability of our chondrocytes at the subchondral bone, subchondral meaning adjacent to the cartilage, in what used to be our growth plates. That bone loses its ability to produce the proteins that contribute to the cartilage and the different types of proteins in whether it be the meniscus of the knee or the disc of the spine and various other areas. So I follow the work of an orthopedist who's been doing this nearly 20 years in France by the name of Philippe Hernegal. And Dr. Hernegal published a landmark paper, and every 5 years they report the follow-up, the cumulative follow-up. And a few years ago, they published the 15-year follow-up of knees. They took patients who were end-stage knee. Their cartilage was gone. They were recommended for knee replacement surgery. And they offered these patients an alternative to join the study. They took half the patients in the study. They injected the intra-articular space, the meniscus of the knee. And the other half, they injected the subchondral bone. So that's a bone injection. And in the early goings, they all had good results in both groups. But by 15 years, they had quite a significant difference where the bone-injected group had still continued clinical benefit, did no longer need the knee replacement. But by the 15-year mark, the vast majority of the intra-articular group injected on to have clinical problems again. And we're having trouble. So they clearly demonstrated in this well-designed study that the biology of joint health, joint regeneration, which we do to ourselves during our youth and just lose that ability over time and with accumulated inflammation and trauma, are the main determinant of the cartilage function of that joint and the health of that joint. Therefore, the regenerative biologics that I use for joints are mostly in the subchondral bone of knees and ankles and other joints. We do hips and shoulders, and I've done, arthritic fingers and all kinds of things.
Well, that's a fascinating study, and it will be interesting to see how that takes off around the world. And yes, you have got competing interests from people that are selling joints, but right. This is medicine moves in interesting ways. How do you think that's working? Can you explain what's happening there biologically? You're injecting this into the chondral bone. What's actually happening there?
Yeah, so these are very sensitive cells in the bone. The stem cells in the growth plates, the chondrocytes that make these proteins, are affected by the metabolism, the biology of the human, and the human is exposed to all types of pro-inflammatory damage accumulated with life, whether it be things in our water we shouldn't be having, things on our food source, we're having gaps in nutrition where we need supplementation, exposure to electromagnetic fields, cosmic radiations, who knows what else, and then injury, which is pro-inflammatory. And then add to that sugar, too much sugar.
Yeah.
And pretty soon you have the most sensitive cells of the body start to show their damage first, like the pancreas, like the joints. So osteoarthritis is really a metabolic bone inflammatory problem. And so we're directing the treatment at the root cause by delivering the biologics like exosomes, which are extremely anti-inflammatory, to the very place where it's needed most, allowing the local cell structure to function better, start to produce those cartilage-like proteins, and improve the joint. And we do have examples of thickening of the cartilage, measured on an MRI done 6 months later, improvement in functional scores, reduction in pain. We're gearing this up for another study so we could do it as well. But by and large, that's what we're seeing.
So I can understand if you're injecting stem cells, the stem cells then epigenetically may become chondral cells. I get that. Here we're injecting these exosomes. And are you arguing that because they have this anti-inflammatory effect, it's allowing the stem cells that are already there to mature more effectively into chondral cells? That's how that process is working? Is that what we understand?
I think so. I think what we're seeing is a stimulation of the local stem cells and stimulation of the local chondrocytes to return to their best and optimal functional, utility to do what they were designed to do and what they had done for many years during our youth, and just because they've been damaged over time, we're just sprucing them up and getting them going again, activating them.
So that's one very big application, and that's a huge problem. I know in Australia, I think knee replacements, it's estimated that's going to overtake hip replacements here very, very soon, if it hasn't already. But it's a huge number of people having knee replacements, and that's all part of metabolic syndrome that you've alluded to in our growing number of people that are overweight and obese. What about other applications in terms of restoration of cardiac function post-myocardial infarction, or the role it might have, say, in terrible neurological diseases, MS and Parkinson's and so forth? Do we have any idea of how this may be applied to other sorts of conditions?
Right. Well, there's really good research on using exosomes intravenous for, cardiac failure syndromes, and post-MI is probably the most common cause of that. So we're seeing that. That's easily done IV, can be part of a cardiac rehabilitation program. Anecdotally, we have some good results in recovery from stroke. The problem is we don't have a well-designed study to compare those people. You'd have to have a cohort getting placebo, and no one wants to sign up their family member for the placebo study. So it's a little bit difficult and tricky to do. It's a little bit more humane in a knee degeneration study, because you can give someone placebo. If they fail, the study's over. They can come in and then get the real treatment. It's a little late with cardiac and neurologic rehabilitation. So most of this is anecdotal, although there are some very good papers on cardiac cardiocyte function, after, and contractility and all kinds of functional measures after use of biologics for recovery from MI.
Neurological diseases, are you seeing any research in the United States about that? You mentioned stroke, but other conditions?
Most of the research is European and Asian. U.S. is a little bit slow. The economic and political pressures, like in other places, slow that down. But we are, anything with an inflammatory component tends to also benefit from the regenerative biologics. So Alzheimer's disease, there's an inflammatory component to the misfolded proteins, for example. We do see functional improvement, and there are good studies there. Different types of glandular disorders, insulin sensitivity, I have a few patients of my own who have had progressive kidney failure. We've been able to help them prevent the need for what was going to be imminent dialysis by use of IV exosomes. Interesting, but also in the gland family, we have a lot of patients with dry eye syndrome, and we've been able to inject the eyelids and stimulate the meibomian glands to produce the the oily substance for the eye as well. So we're looking at all kinds of different things and trying to curb inflammation where we see it.
Yes. Oh, that's fascinating. Well, tell us also, you have a big interest in anti-aging. What's the approach there? And we all want to have a healthy life. We want to give a health span. And, David Sinclair's an Australian. He's written Lifespan.
Right.
We're all quite excited about his work in which he's in the United States. But, health span, it's a big topic. We had Tia write this beautiful book this year as well, Outlive. And I'm not sure if you've read that book, but it's a tremendous book that Peter Attia's written.
Yeah.
But so there's a big focus on this. Tell us about your consideration in regard to this therapy and that.
Right. It's hard to dive into regenerative medicine, even though I did it, with one reason, and not understand that when you slow inflammation, reverse inflammation at the cellular level, you are really slowing what we call inflammaging, which means you're supporting health span, because the cellular concept of it's an accumulated chronic inflammation.
Yes.
So through lifestyle, epigenetics, and now regenerative biologics, we're just hacking our way sort of backwards a bit, and anti-aging and health span and disease, slowing of disease development through this process is just logical. These things all fit together.
You're going to tell me that you're 90, Jeff. You look pretty well here.
Thank you. Now, I'm happy to say I'm 58. And
you do look great.
I feel good. I'm also a patient, so I enjoy the benefits of the exosomes myself. I do them myself, just preventatively. And we have a group of people who do that, enthusiasts who just fly into Las Vegas, stay for the weekend, see a show, have a nice dinner. If you're coming from as far away as Australia, maybe stay a little longer.
and that's an intravenous dose of the exosomes that you're having.
Sorry?
Is that you're taking it intravenously?
I do personally. I've had it intravenous. I've also had my scalp injected. I had some thinning hair here and wanted to try to keep that. So I've had that a few times in the scalp, which is very simple. We have some fun things we do and some skin procedures, some microneedling of the skin for healthy looking and rejuvenated skin. But really the health benefits are from IV or for our patients with joint issues. We also do some we call O and P shots. The O for the ladies and the P for the gentlemen in their genitalia to improve lubrication, sensitivity, function in that department.
Well, I'm sure that'll be popular in due course. I did listen to you talking about that, and I thought I must go and read about that. But thank you for offering that service as well. You've got lots of famous sports teams in America. The Kansas Chiefs and the Philadelphia Eagles came together just recently. Are you getting sports people coming to you saying, "Look, Jeff, we've got soreness, we've got muscle aches and pains. Can you please help our teams?" To reach their sort of physical potential again after a clash of these titanic teams. Are you seeing these people coming to you asking for assistance?
Well, we do see individuals. We don't have teams coming to us because I don't think the teams want to advocate that they're walking on a special path because they their fans may not be able to obtain these services. Not everyone can. Yeah. So they come to us individually, and it's usually quiet. They don't want some of these people have minor to moderate injuries, and they don't tell their employer because they're being uninjured might depend on how much money they make. So a lot of these things are done sort of quietly. They come up to us off season, and we help where we can, and we agree not to not to use their name, image, or likeness.
Yes, I see. Gotcha. Because there's a huge amount of rehabilitation that occurs in Australian rules football, which is very physical and rugby and so forth. So I just wondered how popular that was becoming. Where do you see the future of this work that you're doing? What gives it like your prediction next 10 years? How do you see it filtering out into mainstream medicine? Because it's still a little bit specialised, isn't it? You know, you're in a growing group of people that are applying this, but give us your impression in the next 10 years.
Well, I think you're going to see what we call designer exosomes. So you're going to see exosomes from a group of cells, maybe in cell culture, that were conjured to carry specialized contents and cargo for influencing the neighboring cells upon delivery. For example, certain T cells that fight cancer make exosomes that are known to kill cancer cells. That may not be all cancer cells, but it's a new tool that doesn't require chemotherapy or radiation. It can be, an additive treatment, or even perhaps someday alone be adequate to receive IV or injected into solid tumors. That's very exciting. That's something we have our hands in. I think you'll see others that are better designed to help joints quicker. You'll see more metabolically designated cell. They've got now exosomes that can carry mitochondria in what's called mitochondrial transfer therapy. And these for aging people who are losing their muscle mass and their bone density, this could be quite a game changer, because both muscle mass and bone density are correlated with longevity. So as long as you're moving and you support your muscles by moving and your bones by using your muscles, you're really supporting your one. Minor advice here: it's keep moving. Yes. That was
one of Peter Attia's main conclusions in his book. It's about keeping active and avoiding sarcopenia, which is what you're alluding to then. Yeah. Oh, that's tremendous. How would people from Australia, say, read more about it, get in touch with you, Jeff, if they were coming to the United States and wanted to consider this? How would they do that?
Well, through the magic of the internet. My brand is called Recelebrate, since we're celebrating the renewal of your cells. So RECELLEBRATE. We have a website. We're on all the social media platforms. Just look for us and send us a message or reach out. We love to meet new people from everywhere. We have a lot of medical tourists who come here. Luckily, we're in a good city where people don't mind visiting.
Yes.
Just try not to come in July, August, or September. It's not the most pleasant place to be. It's quite hot, but can if you like. And but we try to do a lot of the head work by Zoom, just like this, Doc. We do this. We have a lot of people who I want to optimize before we even consider a regenerative procedure, because if your body's not receptive, if your cells are missing nutrients and your diet is off and you're inflamed, putting good regeneratives in you aren't going to do as much as they will if your body's ready for them. So we like to really get people ready.
Okay, well, that's tremendous. Jeff, last question. When you're coming out to Australia, you haven't visited the Antipodes, which is terrible. That's terribly sad. We've got everything.
You're absolutely correct. And with your invitation, I think it'll be soon.
Well, that's I'll be dining with you in Melbourne when you come out, Jeff. It'll be
perfect.
To check this out with you.
I accept your challenge.
Well, Jeff, thank you very much for joining me. Really appreciate it.
Thank you.
And I'll be putting your details in the show notes as well, of course. And it's been a real pleasure talking with you. And I'm going to be watching this space with great interest. Thanks for introducing us to this incredible topic. Thank you.
Thank you so much. It's my pleasure.
Thank you. I'd like to thank you all for joining me in the conversation today with Dr. Jeffrey Gross from Nevada, USA. I found this whole subject on exosomes very interesting. Clearly, we're at the start of something very fascinating and hopefully a new vast field of medicine and medical therapeutics will be opened up by this study. Well, during this podcast series, we're going to be covering a wide range of topics. We have another interesting clinical subject to discuss next week with a specialist. I'd like you to join us then. The topics and subjects, though, are not intended as specific medical advice for patients, but more as general information only, and they reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed and may be emailed to manager@geohealth.com.au.